And from this onwards, we will try to conduct the ASI meeting every month. We try for the physical meeting. If not possible, at least we try for the online meeting from this month onwards. And today, mainly we have two programs. One, the case discussion, one by Dr. Lakshmi, and we have a very good panelist. And one of the panelists are the senior most professor Dayandababu sir, and other two professors, Dr. Nisaruddin and Dr. Vishwanathan. And moreover, after this program, this case discussion, we have a invited faculty from Indo-American Cancer Hospital, Hyderabad, Dr. Subramanya Rao. He is the director of that Cancer Institute, and he is going to give us a very good lecture about the anatomy and the surgery. And I think we can enjoy with this case discussion and this invited lecture from this eminent onco-surgeon from the Hyderabad. And after this discussion, we have the ASI association matters, and that Abhilasha, do we have any matters to be discussed today? Unmute. Abhilasha, mute idiriya. Abhilasha, ippo unmute aanu. Mute aanu.
Not have association matters. We'll just have a vote of thanks.
Okay, fine. After this, we straight away go for the vote of thanks. Then yes, can we go to the case presentation straight?
Yes, sir. Yes, sir.
Yes. Now I invite our first panelist, the senior most professor, our Dayandababu sir, Dr. Nisaruddin, the professor of surgery from Government Medical College, Trivandrum, and Dr. Vishwanathan, again from the professor of surgery from Government Medical College, Trivandrum. And today, the case presentation is by the JR3 Junior Resident Final Year, Dr. Lakshmi M. Nair from Government Medical College, Trivandrum. Over to the panelist, sir.
Sir, Dr. Subramanya Rao has also joined us. He is also an onco-surgeon. So he will also be joining us with this also. He has already joined as the panelist here. Now it's
okay, very good, very good.
Also, sir.
Welcome, sir. Welcome, Dr. Subramanya Rao. Welcome to our ASI Trivandrum meeting. Okay, he will join. Anyway, we start.
Thank you very much. Abhilash,
okay.
Chakramon.
Thank you, sir. Thank you, sir.
Latif
Welcome to our ASI Trivandrum branch.
Thank you very much.
And we are inviting for a wonderful lecture after this case discussion. And also, we need your valuable opinion about this case discussion also in between.
Hi.
Okay, thank you, sir.
I hope to do my best, sir. Thank you. Yeah.
Abhilasha, we start.
Sir, we can start with the case presentation. Lakshmi.
Yeah. And first, let the panelist take that post, panelist post. Before starting his presentation, just show the panelist first. Abhilash.
Sir, panelists are Dr. Vishwanathan.
Yeah, Dayandababu sir.
Dayandababu sir and Dr. Nisaruddin.
Nisaruddin. Avara ഒന്ന് കാണിക്കൂ.
Sir,
കാണിക്കാൻ പറ്റൂലേ?
Because slide sharing has started.
Okay, fine. Let us start.
Good evening, everyone. Am I audible?
Yes, you are audible.
Good evening, everyone, respected faculties and dear colleagues. Myself, Dr. Lakshmi M. Nair, and now I am presenting a case on thigh swelling. My patient is a 56-year-old female, a homemaker from Pathanamthitta, presenting complaints, swelling on the front part of left upper thigh for the past 6 months, pain over the swelling for the past 6 months, difficulty in breathing for the past 2 months. History of present illness. My patient presented with a swelling on the front part of left upper thigh, which was incidentally detected 6 months back by herself while bathing. The swelling was initially gooseberry sized and rapidly increased to the present size. No history of itching or redness or ulceration over the swelling. No history of discharge or bleeding from the swelling. It was associated with a continuous, mild, dull aching pain over the swelling since the past 6 months. The pain was not aggravated by walking and not relieved by taking rest. No relief on change in posture. No radiation of pain to the rest of the lower limb. No history of numbness or altered sensations over the limb. No history of difficulty walking. No history of swollen limbs. No history of fever. She gives a history of loss of weight, that is loss of 16 kilogram in the past 1 year. History of breathlessness while walking was also present for the past 2 months. Initially, it was present only on climbing the slopes, but now she develops breathlessness after walking on straight road for about 3 minutes and has to sit down for the relief of the same. No history of cough or hemoptysis, no history of chest pain or palpitation, no history of jaundice, abdominal pain or abdominal distension, no history of constipation, diarrhea or blood in stools, no history of back pain or bone pain, no history of trauma, no history of swelling elsewhere, no history of skin discoloration anywhere, no history of hearing difficulty or tinnitus, no history of blurring of vision or double vision, no history of headache, vomiting or seizures, no history of deviation of angle of mouth. Past history of illness. She had a hysterectomy 20 years back for suspected fibroid uterus. She is having type 2 diabetes on oral hypoglycemic agents for the past 5 years. No history of tuberculosis, bronchial asthma, or cardiac disease. No history of radiation treatment. No history of occupational exposure to chemicals. Personal history. She had a normal appetite. She eats non-vegetarian diet. Her bowel and blood habits are regular. Sleep is adequate and there are no addictions. Menstrual and obstetric history. She attained menarche at 14 years of age, had 3 normal vaginal deliveries. She underwent hysterectomy at 36 years of age. Family history. She had 5 siblings, of which the eldest sister was diagnosed carcinoma of breast at 58 years of age. No history of similar illness in the family. General examination. The patient is conscious, cooperative, and well-oriented in time, place, and person. Her height is 167 centimeter, weight of 43 kilogram, BMI is 15.46. Her ECOG score is 2. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema. Her pulse rate is 78 per minute, regular rhythm, normal volume and character, condition of vessel wall, normal in right radial artery. All peripheral pulses present equally bilaterally in all 4 limbs. Blood pressure is 130 by 90 millimeter mercury in right arm in sitting position. Respiratory rate is 20 per minute, regular. Temperature is 98.6 degree Fahrenheit. Local examination. Patient was examined in a well-lit room in supine position with both legs resting straight on the bed. After ensuring adequate privacy, patient was exposed from umbilicus downwards. Inspection. An overt swelling of size about 12 into 5 centimeter is seen over the upper anterior aspect of left thigh. All borders are ill-defined. It extended superiorly about 10 centimeter below the anterior superior iliac spine, inferiorly about 20 centimeter above the knee joint, medially about 3 centimeter lateral to a vertical line along the midinguinal point, and laterally up to a vertical line along the anterior superior iliac spine. Surface appears smooth. The skin of the swelling was normal except for 3 small biopsy scars. No skin ulceration or discharging sinuses over the swelling. No dilated veins or visible pulsations over the swelling. Palpation. No local rise in temperature, no tenderness. A single overt swelling of size 12 into 5 centimeter is located over the upper anterior aspect of left thigh. It was variable in consistency, varying from firm to hard, irregular surface. All borders are ill-defined. The extent was superiorly about 10 centimeter below the anterior superior iliac spine, inferiorly about 20 centimeter above the knee joint, medially about 3 centimeter lateral to a vertical line along midinguinal point, and laterally up to a vertical line along the anterior superior iliac spine. The swelling was mobile in both directions, more mobile horizontally than vertically. On contracting the quadriceps femoris muscle, the swelling becomes fixed and less prominent. The skin of the swelling was pinchable. Auscultation, no bruit over the swelling. Examination of rest of the left lower limb. Position and length was normal. Left dorsalis pedis, anterior tibial, posterior tibial, popliteal and femoral pulsations are present. Sensations are normal. Muscle bulk and power normal. Movements and joints intact. No pedal edema, no dilated veins, no skin discoloration, no other swellings. Examination of lymph nodes, no enlarged inguinal lymph nodes. Head to foot examination, no pigmentation of skin, no eye pigmentation, skull and spine, normal. Examination of other systems, cardiovascular system S1, S2 normal, no murmurs. Respiratory system normal, vesicular breath sounds bilaterally, no added sounds. Gastrointestinal system, abdomen soft, no organomegaly. Nervous system, no focal neurological deficits. So coming on to the summary, a 56-year-old female, non-diabetic, presented with a swelling in the front part of upper left thigh for the past 6 months, which was rapidly progressive in size and associated with a continuous mild dull aching pain over the swelling. History of significant loss of weight and exertional dyspnea are present. The examination revealed a single overt swelling of size 12 into 5 centimeter on the anterior aspect of upper thigh, which was firm to hard in consistency with irregular surface, ill-defined borders within the quadriceps muscle, not fixed to femur or skin, and rest of the limb was normal. So my diagnosis is soft tissue sarcoma, left thigh, staging C T3N0MX. Sir.
Dayanand Babu sir, Vishwanath here.
Yeah,
Sir, start sir.
okay. Dr. Lakshmi, you said so many in the history, so many things, no history like that.
Yes, sir.
What is the importance of history of trauma?
The history of trauma, actually, there are some controversies regarding the history of trauma. Some consider that a trauma can later on predispose to a swelling like in myositis ossificans.
Any other swelling related to trauma?
There can be other than sarcoma, there can be trauma-related hematoma or infected hematoma, but the duration is again against that.
There is something called desmoid. You know that desmoid, there is sometimes you get history of trauma.
Okay, sir.
Desmoid. Then
Okay,
you
sir.
said bone pain. What is the importance of bone pain?
Bone pain, one can be the invasion into the bone, invading the cortex of the bone can cause a bone pain, infiltration of the bone.
Any other cause?
Sir?
Any other cause for bone pain? Maybe bone sarcoma.
Can be sarcoma.
Bone sarcoma also. What is the cause for this loss of weight?
Sir, loss of weight is usually cachexia in the malignancy.
16 kg for, this is not a very big swelling. It is not a very big swelling and the duration is only 6 months, and then I don't know, 16 kg loss. And what is the cause for breathlessness? Did you elucidate further?
Sir, the breathlessness started 2 months back, and it is gradually progressive. Now she is having exertional dyspnea even while walking about for 3 minutes. Breathlessness may point to malignancy with metastasis, sir, because in soft tissue sarcoma, the most common site of metastasis is lungs. So it can be,
But you said that chest examination is normal, isn't it?
but chest examination, yes, chest examination was normal, sir.
So then what is the cause then?
It can also be unrelated to the malignancy, sir. Any other cardiac causes, underlying cardiac causes, maybe we don't know.
No, you repeatedly said no pigmentation. What is the importance of pigmentation?
Sir, pigmentations mainly occurs in, if you are suspecting neurofibromatosis, there can be cafe spots.
What is the definition of cuff-light spot? What is cuff-light spot?
Definition, I don't know, sir.
When do you say that patient has got cuff-light spot? Just any pigmentation is cuff-light
No.
spot?
No, sir.
And when do you say? There should be, you don't know?
I'm not sure, sir. I don't know.
There should be more than 6 or more cuff-light spots, each having 1.5 centimeter diameter. Any other association of the multiple or von Recklinghausen's disease? What type of disease is that? Von Recklinghausen's disease.
In neurofibromatosis type 1, it is a benign disease, sir. I mean, so due to the mutation.
It is an autosomal dominant.
Dominant disease, sir.
How many percentage are autosomal dominant?
I don't know, sir.
What are the other associations other than cuff-light spots?
There can be pigmented hematomas of iris.
What is it called?
Irish nodule.
Lish nodule. It is called lish nodule.
Lish nodule.
What are the other associations? What is, have you heard of freckling of armpits? Freckling.
Freckling of armpits. Armpits.
So, is there any freckling? Did you look for it?
No, sir. No, there was no freckling.
No freckling?
No freckling.
Other association, quickly you should say. One or two more, most important. Any bony anomalies? Did you examine the back?
The skull and spine was normal, sir. No associated kyphoscoliosis.
Any other bony abnormality possible in von Recklinghausen's disease?
One is kyphoscoliosis. Next is
Dysplasias of bones. Have you heard of dysplasia? Dysplasias. Long bones, thinning of long bones.
Okay, sir.
Dysplasia of sphenoid.
Okay.
And sometimes optic gliomas, out of which out of which 2 must be there.
Okay.
So that is about the pigmentations you said. So always you should mention no other swelling, any other swelling anywhere. So you should examine you should examine the entire body. Otherwise you will miss. What is the BP like? What is the blood pressure like?
Blood pressure was a normal, sir. 120/70.
What is the blood pressure? Nor.
Sir?
Suppose there is hypertension, what do you suspect? Hypertension.
Sir, any intracranial?
Intracranial?
Shrine.
maybe pheochromocytoma, which is associated with the neurofibromatosis. So that is a possibility, isn't it?
Yes, sir.
So examination, and I don't know why your chest is clinically normal with all these findings, and why 2, 3 on examination you said 3 small biopsy scars.
Yes, sir.
What is this? What are these 3 biopsy scars?
For this patient, the initial biopsy, true cut biopsy, which was done was inconclusive. So another biopsy was sent. Usually for soft tissue sarcoma, adequate tissue should be obtained for correct diagnosis. And the
Why?
first specimen was in
Why?
Because in biopsy specimen, this soft tissue sarcoma, some areas can be normal, that is benign like. So if only a small portion is obtained for biopsy, we can mistake it for a benign diagnosis, benign tumor. But
So
actually it may be,
you always need a excision biopsy then? No.
no sir, no sir.
Why you need a core biopsy?
For core biopsy is needed because first is to confirm our diagnosis. Then next, if the patient is having a large swelling, then we would actually go for a neoadjuvant chemotherapy. So
No.
biopsy.
Don't go for those things. You need the grade.
For
Oh,
grading,
understand.
because
Why you
the,
need grade?
because in soft tissue sarcoma, the staging depends on the grade also. Apart
So
from
grade is
the grade is important in staging.
Grade is included in the staging. Therefore, you need the grade. So
Yes,
you have done, or for this patient, you have done once core biopsy. Second time, what was done?
yes, sir. Second time also it was done.
Core biopsy.
Core biopsy was done.
Third time, you said 3 scars.
Yes, sir. First was inconclusive. Second biopsy came as benign, but according to the history, we could suspect a malignancy, so we sent again a true cut biopsy.
I see.
Both the first two was done outside, and the third one was done in our center.
Okay. And what is the plane of the swelling?
The plane is deep to the deep fascia and intramuscular, sir.
Intramuscular. Which
Yes,
muscle is there? Which muscle?
Quadriceps femoris, sir.
So it is from the muscle, according to you, not deep to the muscle.
Yes. From the muscle, sir.
From the muscle, right. And did you mention about the movements of the joints distally and proximally?
Yes, sir. I have mentioned it. It was normal.
Normal. Did you mention about the measurement circumference? Any wasting?
I didn't. No, I have mentioned no. The basal bulk and power was normal.
No wasting.
No wasting, sir.
No. Okay. I think Dr. Vishwanathan.
Sir. Yeah. Lakshmi?
Yes, sir.
Yeah, can you hear me?
Yes, sir. I can hear you.
So what is the orientation of the swelling? What is the long axis?
Long axis, it is ovoid, longitudinally ovoid. Sir, it was longitudinally ovoid, that is 12 centimeter vertically and 5 centimeter horizontally.
Okay.
And the upper border, all the borders were ill-defined. We could not definitely define, but the extent seen was, upper extent was 10 centimeter below the anterior superior iliac spine. Lower extent was 20 centimeter above the knee joint.
Okay.
And
so
the medial and lateral.
what is the length of a normal femur? Female femur? In centimeters, roughly calculating all this, 10, 20 is the total length of the femur?
Sir, the first measurement what I said was from anterior superior spine, sir.
Yeah, you took it from the anterior superior leg spine. Okay,
Sir?
still, what is the length of a normal femur? What is the length? If you look anteriorly, the length of the thigh compartment from knee to the inguinal region.
Mm,
Yeah, it will be around what you have said, 42 to 45 centimeters. Anyway, I just wanted to highlight that you should be, when you measure the dimensions and when you say all these, you should be very careful about it. Shouldn't exceed the length of the normal adult thigh. You should be careful about that.
okay, sir.
Intermuscular lesion, right?
Yes, sir.
Is there any involvement of the skin?
Sir, I can't hear you, sir.
Is there any involvement of the skin?
No, sir. Skin was normal and skin was pinchable.
Pinchable. How did you make out the intermuscular location?
When I contracted the quadriceps femoris, the swelling, the swelling,
Carry on.
sir, when I contracted the quadriceps femoris, first the swelling decreased in size. It did not disappear, but decreased in size, and
Yes.
And it was fixed that the mobility was lost.
Mobility was lost.
Yes, sir.
Okay. So, was it mobile otherwise?
Otherwise, it was mobile in both directions, but vertical mobility was less than horizontal mobility.
Okay. Now, you said about pain in your history.
Yes, sir.
What are the reasons for pain? You said this is a dull aching pain. What could be the
Yes,
dull
sir.
aching pain due to?
It can be due to the stretch of the surrounding capsule, sir.
Okay, it's a very, you said mild dull aching. So, don't use, you said mild dull aching pain. Right?
Yes, sir. Mild aching pain.
It is continuous.
Yes, continuous pain, sir.
Okay, so what about the neural pain? Suppose which nerve can, if it is affected anteriorly, you get that.
If there was nerve involvement, it could have affected the saphenous. First thing would be affected will be the saphenous nerve, which is the cutaneous branch of the femoral nerve, sir.
So, what did you test for the sensations?
Yes, sir. All sensations were normal.
Normal. Okay.
Yes, sir.
What is the nerve of the anterior compartment?
Femoral nerve, sir.
Femoral nerve. Okay. What are the muscles in quadriceps?
Muscles of quadriceps femoris are, one is rectus femoris, vastus medialis, vastus intermedius, and vastus lateralis.
Okay. Which do you think, which is the superficial of this?
Rectus femoris, sir.
So do you think this is arising from rectus femoris or deep to it? Difficult to tell, right?
Difficult to tell, sir. Separately.
Okay. So if supposing there was weakness of the quadriceps, what will you look for? Involvement of the quadriceps, weakness. Supposing this was a swelling, neural swelling.
I'd look.
Tumors can arise from the nerve also. So.
Yes, sir. Femoral. Then I'd suspect the involvement of the femoral nerve, sir.
Okay. Suppose there's quadriceps weakness. What will be the gait of the patient?
Stamping, quadriceps weakness. Dragging it.
What typical? That's a typical position the patient will walk with. You know, the hands on the knees, and patient will try to extend with the hands. So there will be a limping to that side, and stooping to the side, the patient will hold the knees, and she learn to fix the knees and walk. So there will be a the quadriceps gait, or what is called, right?
Okay, sir.
Gait is also important. Then, as Jayananda Babu sir asked, did you check for the muscle wasting?
Yes, sir. No muscle. There was no muscle wasting. Bulk was normal.
Okay. Right. Nisar?
Okay. Nothing more left for me to discuss or ask questions. So everything is covered, but still I want to ask some clarification. Because the swelling is located or situated on the anterior aspect of the thigh, and I am not going into the details of the length because it was already discussed by Vishnu. And I want to know whether this swelling is confined to a single compartment or it is extending beyond the anterior compartment.
A single compartment, sir.
It is confined to the anterior compartment.
Anterior compartment only.
And the rectus muscle or the rectus femoris.
Yes,
And
sir.
it is not extending either medially or laterally.
No, sir. Only the anterior compartment.
So it is not any clinical evidence to suggest that it is attached to or it is extended to the periosteum or more. It
No,
is
sir,
freely mobile.
because it was mobile on when the rectus femoris was relaxed. I mean, quadriceps femoris was relaxed. The swelling was freely mobile in both directions.
Okay. Or even in the relaxed position, the swelling is mobile. That
Mobile,
means
sir.
the neutral position it is mobile. So it is taken for granted that it is not confined or it is not fixed to or it is extended to the periosteum or the bone.
Periosteum.
Then the second thing is definitely this patient was initially evaluated elsewhere. I understand that. So it was evaluated in centers outside the medical clinic.
Yes, sir.
It was initially evaluated elsewhere.
Yes, sir.
All the 2 biopsies or the 3 biopsies were done outside.
No, one biopsy, last biopsy was done in our center, sir.
Outside. Was it a planned incision or the incisions are oriented in such a way that it can be removed?
Yes, sir.
to keep the surgery?
Yes, sir. The incisions were straight and above that, so that if we plan an excision of the swelling, it could be removed easily.
This can also be included in the surgical
Yes, sir.
surgical field. Okay. So
Yes,
there
sir.
was a longitudinal. Obviously, it should be a longitudinal.
Sir?
It's a longitudinal one. It is along the long
Yes.
axis of the.
Yes, sir. Yes, sir. Yes, sir.
What about the previous SPR? Have you reviewed? Or what prompted you to repeat the biopsy?
One is because the history wise, one is the age and the age of the patient with and history wise, the rapid growth of the swelling pointed towards malignancy, and the breathlessness again we suspected metastatic, so it could be malignant. And the examination wise, the swelling was variable in consistency, varying from firm to hard. Again, we could suspect a malignancy, sir.
Okay, then still there was an option that you could not proceed with the true cut biopsy. Do you agree or not?
Sir?
Still there is an option, even though there were 2 open biopsies in the past.
No,
There is
sir.
an option for a true cut biopsy. Why
Sir,
it was not attended?
Sir, biopsies, all the 3 biopsies are true cut biopsies, sir.
Oh, it is true cut biopsy, not
All
open.
the 3, no, all the 3 biopsies are true cut biopsy.
Okay, well, there is no question of orientation of incision like that. Okay, so in the third which we performed is in this institution in our hospital, and it was a true cut biopsy.
Yes, sir, true cut biopsy.
So you are awaiting the result.
Yes, sir.
Awaiting the result. Then what about the
awaiting.
breathlessness? Do you think that this is significant as far as the thigh swelling is concerned?
Can be significant, sir, because the most common site of metastasis from soft tissue sarcoma is lungs. But examination with the chest was clear. We couldn't get any other signs.
So is the breathlessness is the common way to present a metastasis or to presentation of a metastasis?
No, most common is asymptomatic. Most patients will be asymptomatic initially.
And if there is a symptom, what will be the commonest symptom in metastatic lesion?
Cough.
I mean pulmonary metastasis.
Cough. Cough.
What about hemoptysis? Is it possible?
Hemoptysis is also possible, sir.
Anything is possible. Okay. Then weight loss. What was the original weight of the patient? 56-year-old female
60,
having 6 months history.
yes, sir. She
You
was not.
commented that there is a 16 kg dose of it over
Yes,
the
sir.
past 6 months.
Yes, sir. So, no, 16 kg weight loss in the past 1 year, sir.
1 year.
1 year.
Okay, finally you made a diagnosis of soft tissue sarcoma.
Yes, sir.
Sir, Babu sir,
Lakshmi, what
Yes,
are
sir.
your differential diagnosis and why you are diagnosing soft tissue sarcoma?
My diagnosis is soft tissue sarcoma. One is the age of the patient, which is 56, which is the one which
You
comes within
cannot,
the age.
you cannot get benign tumors in this age group.
Yes, yes, sir. We can get.
So what are your differential diagnosis? So age is not the criteria.
No, sir. First is the history-wise, the rapid growth of the tumor, which is suggestive of malignancy. Next is the history of loss of weight, and again, examination-wise, there was a firm to varying consistency, firm to hard swelling, which was intramuscular, deep, which was in the deep plane, intramuscular. Um, so I could go for the diagnosis of soft tissue sarcoma. And the location-wise, the swelling was in the thigh, which is again the most common site for soft tissue sarcoma.
What are the benign swellings there?
The benign swellings, it can be one. It could be benign.
What is the
swelling.
commonest benign swelling there?
The soft tissue tumor, benign soft tissue tumor.
Yes. What is the commonest benign soft tissue tumor there?
It can be an intramuscular lipoma.
Lipoma, you should, I think you should always suspect lipoma or exclude lipoma. Any other differential diagnosis there?
Benign tumor.
Lipoma,
Desmoid,
hematoma, angiomyolipoma, all those things. Myositis ossificans. So
Okay, sir.
you should not be very myopic and insist that it's only a soft tissue sarcoma. What is a soft tissue sarcoma by definition?
By definition, it is a malignancy of the mesenchymal cell origin, sir.
No, I think exactly what you should tell is it is arising from undifferentiated mesenchymal stem cell. Undifferentiated mesenchymal stem cell. So
Okay.
if at all, if it is soft tissue sarcoma, what type you are expecting?
Histological type, sir.
No. Which is the commonest type?
Undifferentiated pleomorphic sarcoma, sir.
High grade undifferentiated. What is the old name for that?
Pleomorphic malignant fibrous histiocytoma.
Malignant fibrosis. So it is undifferentiated pleomorphic sarcoma. What are the other sarcomas possible?
A liposarcoma can be possible. Then malignant peripheral nerve sheath tumor is possible. Then again, myxofibrosarcoma can be possible, sir.
What are the types of liposarcomas?
Liposarcoma, a myxo type, pleomorphic type, round cell type.
Myxoid round cell, pleomorphic. But there is one soft tissue sarcoma which is least malignant. What is that?
I don't know, sir.
It's called atypical lipomatous tumor. This is differentiated. Atypical lipomatous tumor. And that is differentiated. Suppose your core biopsy, you suggest core biopsy initially, or you do something else before your core biopsy?
First should be the imaging, sir.
What imaging you do?
MRI would be preferred in the thigh region, sir.
Why?
Because MRI is better to delineate the soft tissues and the nearby structures, and also to know the invasion of the nearby structures like vessels and nerves.
Which vessel is there in the anterior compartment?
Femoral artery, sir.
That is higher up.
Here.
But your swelling is little lower, isn't it?
Yes, sir.
Why not CT?
CT, we could, sir, the correct differentiation of invasion into these structures cannot be made by MRI is better than CT for those.
Okay, CT, in which area you prefer CT?
Retroperitoneal sarcoma, sir.
Okay. So, after imaging, you will do core biopsy, isn't
Yes,
it?
sir. Yes, sir.
Any other investigation?
I mean, before core biopsy?
No, before or after?
Sir, for this
You have
patient, CT chest should be taken, sir. Metastatic.
CT.
Metastatic.
Why not X-ray chest?
X-ray chest, if there is any metastasis, only X-ray chest detects only about 60 to 63% of the metastasis, and rest of them can go undetected, sir.
What is the peculiarity of soft tissue sarcoma metastasis? What is the distribution of metastasis in soft tissue sarcoma?
I don't know, sir.
Usually it is peripheral and it is better detected in CT. So you have done MRI of the thigh, then you have done core biopsy, and you have done CT. Any CT finding? Any CT finding in your?
For this patient. For this, no, sir. This patient we have given the request. This patient came last week only, sir, for the first time in our OP.
So it is not taken, eh?
Not taken yet.
Waiting.
Yes,
waiting
we are
for
waiting.
CT.
Waiting for the
So
CT.
meanwhile, you must have taken X-ray test. Any finding there?
No, sir. No findings in the X-ray test.
So I don't know still what is the cause. Maybe some cardiac cause for the dyspnea.
Cardiac cause, we have ECG wise, there is we couldn't detect anything significant, but we have sent a cardiology consultation because we also suspect the other way, that is maybe cardiac related.
Right. So any more investigations required for this patient?
No, sir. With the MRI, we could delineate. We can delineate the tumor, and with the true cut biopsy, we could grade the tumor, and that will lead to the staging, and which will then we can pass on to the management, sir.
So what is the core biopsy report?
It is awaiting, sir. Our core biopsy, initial core biopsy, which was two core biopsies were taken from outside. One was inconclusive, and the other was like schwannoma.
So suppose your core biopsy says small round cells are seen. What will be your approach? What are the causes for the small round cells? Now, basically, you classify into round cell and non-round cell pathologically. You understand?
Okay.
Lakshmi,
okay,
basically
yes,
you
sir.
classify into round cell and non-round cell.
Round
So
cell.
here you are saying small round cells. What are the possibilities?
I don't know, sir.
That is very important. The most important point is to check whether small round cells are there or not. If small round cells are there, that means there is no role, not much of role for surgery. The differential diagnosis are rhabdomyosarcoma, or maybe Ewing's, or maybe even lymphoma, leukemia, etc. So once you find small round cells, your approach totally changes to a non-surgical method, that is in the form of chemotherapy. So first thing is decide whether small round cell or non-round cell, and then you go for the grade. But you are still expecting the result, eh?
Yes, sir.
Okay. So you don't need any other investigation. You go for, you said cardiac. Any other investigation is required?
No, sir.
So no more, no metastasis. And is it operable or not?
It is operable, sir.
Why you say it is operable?
Because in this lesion, it is a large size tumor, that is more than 5 centimeter tumor. We could give a neoadjuvant chemotherapy and then go for surgery, sir. And the limb sparing surgery will most probably be possible in this case, sir.
What surgery I am asking?
Limb sparing surgery, sir. I mean,
Limb
wide local
sparing?
excision with 2 centimeter. I mean, wide local excision with 2 centimeter margin, sir.
Okay, why you need wide local excision?
First is because the soft tissue sarcomas usually have a pseudo capsule around them, and through the pseudo capsule, the tumor tissues can grow through the pseudo capsule. So if we are enucleating or removing the pseudo capsule, it can lead to R1 resection only. R0 resection could not be attained. So we are keeping a margin of 2 centimeters, sir.
You remove the pseudo capsule or include the inside you remove?
No, sir. We remove a 2 centimeter of normal tissue around the pseudo capsule, sir.
Around or outside the pseudo capsule?
Outside the pseudo capsule.
What are the components of the pseudo capsule?
One is a compressive zone and another is a reactive zone, sir.
Zone of compression, zone of reactive zone. Right.
Reactive zone.
Right. So it will go beyond that. That is why you
Yes,
do
sir.
wide. What is the surgery called if you are going inside and removing? Inside the pseudo?
Enucleation.
No, it's called intralesional excision.
Intralesional excision.
Not to be done. Suppose
Yes, should
you
not be done.
just go outside the periphery alone. What is it called? Marginal excision. It's called marginal excision. So you go for the 2 centimeter wide excision, isn't it?
Wide excision. Yes, sir.
Okay. Vishwanathan.
Sir. Lakshmi.
Yes, sir.
That has asked almost but what is required for your examination. Anyway, just one or two things that I would like to ask you.
Yes, sir. Sir?
Kelkamo.
Okay, sir.
Okay, so what is the role of PET scan? You said there is no other investigation required. Is there any role for PET scan?
PET scan is not very useful in soft tissue sarcoma, sir, because even benign tumors can take up can show uptake, so it is not useful.
It is not useful, but they say that because the mitotic rates are high, you can detect a malignant transformation, right?
Okay, sir.
Tumor which is being followed up. Anyway, that is something it is not to be considered now. You said one more thing, that this patient requires a neoadjuvant chemotherapy. What is the criteria for
Yes,
neoadjuvant
sir.
therapy?
Neoadjuvant chemotherapy should be given for a tumor more than 5 centimeter and intermediate to high grade tumor, sir.
More than 5 centimeter. I think straight away neoadjuvant is considered for more than 10 centimeter, right? Or
Uh,
has changed. Between 5 and 10, I think it is for some specific type of sarcomas.
okay, sir.
If it is synovial or something like that, there will be
Okay.
role for a neoadjuvant between 5 and 10. I think about 10. Subramaniam sir is here, so I think sir can add on. More than you go straight to neoadjuvant. Anyway, what is the drug? What are the regimes, chemotherapy regimes?
Doxorubicin is the most preferred one. Then there is also ifosfamide, sir, and
Oh.
dacarbazine.
Okay, role of radiotherapy?
Radiotherapy is used along with the surgery. Sir, it can be like a brachytherapy or external beam radiotherapy, and there can also we can also give free of radiotherapy.
I have a request to the panelists.
Yes, sir.
Please wind up the discussion within 5 minutes because our invited faculty is waiting for that lecture.
Okay.
Please.
Okay. Okay. So the last question that I would like to ask is, what are the known regimes, chemotherapy regimes, you know?
Regimes.
Something like Cyvardic, MAID, MAP.
Right.
Okay, okay, right. Sir, that's all. I think, Nisar?
Yes, Lakshmi, one thing. See,
Yes, sir.
what was the imaging investigation done for this patient?
MRI, sir. MRI.
MRI already done.
Yes, sir.
What
I
was
mean,
the
we are awaiting the result. We are awaiting that we have.
what was the sequencing? The biopsy was done prior to MRI or after MRI?
Outside biopsy.
No, our biopsy. So what is the sequence? What is the usual or logical sequencing?
It
You do
should
it
be done
after this one or
after, sir.
after imaging.
After imaging.
We will plan a biopsy, but here it was not possible because of our constraints, isn't it?
Yes, sir. Yes, sir.
Okay. Then second thing is,
And Dr. Vasu,
hello.
few comments, Lakshmi. One
Sir.
is can you hear me? Can you hear me? Yes. Please avoid that word known. We can you said non-diabetic. We are not sure whether it is KNOWN known or NON known. So avoid it in presentation.
Okay, sir. Okay, sir. Okay, sir.
The distance from the anterior superior spine, there is a joint in between. So the position of the joint can affect the distance from the anterior superior spine. So you should have selected the some fixed point in the same board. Then
Okay, sir.
third one is Dr. Nisaruddin has asked one question.
Okay. Then the second question is the breathlessness. You have to investigate the reason for breathlessness. And
Yes,
we
sir.
cannot
Yes,
take it for granted that it may be due to metastasis. There are
Metastasis.
certain criteria by which we will assess the metastatic potential of the tumor. So
Okay,
what is the percentage of pulmonary metastasis in soft tissue sarcomas, especially extremity sarcomas? So you cannot do all the investigation for all patients. So when it is definitely indicated, definitely we have to do. So will you do CT scan first for all tumors, all soft tissue tumors?
No, sir. No, no, sir. No, sir.
What are the criteria for CT test in extremity sarcoma? Any
So
role
high
for
grade.
size? Any role for size, grade?
Sir, more than 5 centimeter, high grade and deep tumors, sir.
Okay, deep tumors and more than 5 centimeter high grade tumors definitely, because the percentage of pulmonary metastasis even in extremity sarcoma is 10 to 15%. So
Okay,
all the patient will not have pulmonary metastasis. So you have to select the investigations rather than investigating in a haphazard manner. So second thing is you have to investigate the breathlessness. What is the reason for it? It can be pulmonary or it can be cardiac. So
Cardiac.
that also we have to assess prior to the definitive procedure.
Yes, sir.
Okay, then you said it is you will go for neoadjuvant. Again,
Yes, sir.
in this case, what is the indication for neoadjuvant? Neoadjuvant chemo or neoadjuvant chemotherapy? You said. What is the role of chemotherapy in soft tissue tumors? Is the
In this patient, sir, in this patient, as the size of the tumor is large, and if the histopathology comes as high grade, then we can go for neoadjuvant. First is to know the response in vivo response of the tumor to the neoadjuvant chemo, so that after surgery we can proceed with the same regimen. And also another is to downsize the tumor so that surgery is possible. Sir.
Any role for radiation?
Yes, sir. Sir.
Sir, if you are considering neoadjuvant therapy, will you consider radiotherapy or chemotherapy first?
Consider chemotherapy, sir, because even though neoadjuvant radiotherapy is given, because neoadjuvant radiotherapy compared to adjuvant radiotherapy, neoadjuvant radiotherapy is less less harmful to the surrounding tissues. But if you are considering surgery, the specimen that we get will be distorted, and the chance of wound infection complications will be high. So
suppose the periosteum is involved, what will be your choice if the periosteum is involved in this case?
It is involved. Periosteum is involved. We remove the tumor along with the periosteum, sir.
So
because
you
chance
feel that the periosteum will act as a barrier.
Yes.
So what is
yes,
the barrier concept in soft tissue sarcomas?
The barrier concept is that the perinuria, the adventitia of the blood vessel, and periosteum can act as a definite barrier for preventing the invasion into the structures, sir. So we can safely remove the tumor along with these barriers, sir.
If the barriers are involved,
sir,
and if the barriers are involved, will you opt for a surgery? If these barriers are involved, will you still opt for a surgery, or will you consider some other radical measures? I am talking about the extremity sarcomas.
Go for amputation or something.
Yes, sir, we can go for amputation.
Yes, amputation, if you can, you feel that you can control the disease locally, and there is no chance of, or there is no distant metastasis, and there is no chance of metastasis elsewhere. And in that situation, you can go for a radical surgery like amputation. Okay.
Okay, sir.
That's all.
Shall we move on to the next session?
Yes.
Before this, Abhilash, I would like Subramaniam Rao sir to give any comments if he clinical case discussion.
Hello, Anish.
Dayanand Babu and Dr. Vasu and others, I've actually listened to only a small part of it. I'm still in the operation room. I think it was a very incisive discussion.
Sorry,
am I audible?
Sorry, sir, I lost my connection, sir.
Yes.
You're audible, sir.
Yeah. For a general surgery situation, I think it was an excellent discussion, and the girl did reasonably well. Dayanand Babu sir is somebody whom I keep meeting, bumping into. I used to keep bumping into before the COVID time. So it's always a pleasure to see him.
Thank you, sir. Thank you, sir. Right.
Abhilash, you are muted. Unmute yourself.
Sir is the director of Indo-American Cancer Hospital in Hyderabad. He did his MBBS from Kakinaya Medical College in Warangal, and he did this PGMS in Osmania Medical College and his MCH from Kidwa Institute in Bangalore. And Sir also has got a connection with Kerala, and I now invite Sir to give his invited lecture.
Already. Can you see the screen, Abhilash, Chandramohan?
Yes, sir. Yes, sir.
Yes, sir.
Screen is seen? Full slideshow? Hello?
Yes, we can see your slides.
Yes,
Okay.
yes,
Okay.
let's us see.
Yeah. Now let me thank both Chandramohan and Abhilash and the rest of the organizers for being responsible for my presence here virtually with you all. Thank you very much for this privilege, and it's always good to connect with these two gentlemen. We used to meet very often, and I am really waiting to see them in person. I was not the best of the students in MBBS. It was excellent, amazing to get into MBBS, but in the first few days itself, I was told that the anatomy is the stumbling block. If you don't clear that, you get into a referred batch. At least that's what was the convention then in the erstwhile Andhra Pradesh, and then you will lose a bit of confidence and you might lose direction. So anatomy was extremely important. So there was tremendous pressure. I was somebody like him, and the examiners would wait like this for my answers. And all the learning then was from the cadaver. After all, the cadaver's prayer is not something that is new to all of us. But what we need to understand is medicine is a field where the dead actually teach the living. It's not the reverse. That is, so we do need to respect cadavers, because they were the ones which have initiated our surgical training much before we ever imagined that we could become surgeons, all of us. My worry in the late 80s was when I made it into general surgery was, what if I make the wrong cut? It's not cadaver anymore. It does produce pain, and it can produce significant morbidity. While I learned general surgery and got into surgical oncology, I was actually surprised that the entire philosophy in surgical oncology was perpendicularly opposite to what I learned during MS. Two of those clinical situations were this. I was quickly told by my bosses that I should not be identifying recurrent laryngeal nerve in the 80s. If you identify, the chances of injury are more. It was disproved later on, but that's what I have learned. And then in the neck, when I'm doing a left supraclavicular node biopsy, don't dig for the thoracic duct. If you do it, the chances that you will injure small ductules or the main duct itself is very high. But when I went to Kidwa Memorial, I've understood that what they taught was just the opposite of what I've learned. So I had to seriously unlearn things. It was a bit confusing. So ultimately, it was pure anatomy that was different. So you go and hit the nerve and then dissect everything free from it. So see the nerve, see what you want to preserve has to be seen first, whether it is the duct or the nerve. So this is something that I have to unlearn and learn. It's all anatomy at its best. What I've realized is, from an anatomical perspective, surgery is actually to remove what needs to be removed, to retain everything that needs to be retained, to reconstitute what is remaining, and reconstruct if it is necessary. all this, when it is done on the anatomy, it actually becomes surgery. What the younger ones might not have realized is anatomy is universal. And universal means irrespective of the race, most of the anatomy, actually all the anatomy remains the same. A rectal nerve in a Caucasian, in a Mongol, in an Asian or a African American remains the same. And that is the reason why we keep traveling. Chandramohan, me, all of us keep traveling and then operating in many places. And foreigners come here and operate. They are not new because the anatomy is the same. The operation room may be different, the scrub nurse may be different, but the patient is the same. And anatomy is a true socialist. It does not change with ethnicity, race, or richness. Irrespective of what you are, the anatomy remains the same. And what is also important is it has not changed since time immemorial. For a few hundreds of years, anatomy has remained the same, and there is not actually much to learn new. It's not as simple as we would think when you become a surgeon from an anatomist. Fear in surgery is not because of the heterogeneity of the disease. The confusion is not because of the variety of problems. The problem is, the fear is because of fear of anatomy, particularly from anatomical variation, which you would have not picked up. That brings us to this all-important aspect of anatomy in the lives of surgeon. I remember and dedicate this talk to these two great teachers of mine. Professor Saumitri was somebody who believed that anatomy is the beginning and end of medicine. That's what we would pick up. He would love the subject so much that he would stay back in the dissection rooms beyond the last student. Such greatness and love for his own subject, which was not all that respected when compared to surgery, medicine, pediatrics, or orthopedics in those days. The second lady is Professor Geeta Rangarao, somebody whose love for students was way beyond any professor would ever show. It's not just a student-teacher relationship, but much beyond. Beyond that, she would look after the welfare of each student, apart from training them in anatomy, every aspect of anatomy. For her 60th birthday, she was in my place, and what had happened, why I said I was not the best of the students, was she was actually asking us one secret, the story of the sciatic nerve. On our cadaver, the sciatic nerve was cut without identification. And I know the PGs and the consultants would know that the sciatic nerve is the thickest and the strongest nerve, and even for the strongest surgeon, it's not easy to cut. But we managed to do it without actually identifying. So she actually made me promise that I will never choose surgery as a specialty. And only then she told me she would pass me. She did pass me. And then only thing that I did not follow is that her advice. Then I became a surgeon and actually ended up operating on her later on. If there is science and art in life, if you combine them, that becomes surgery. It is initially, while you are learning, it's much more science than art. Once you learn a bit of science, it's predominantly art, and that's what separates the best surgeons from the rest. And the art component of it is actually uncovering, unfolding, and unfurling anatomy. Anatomy, as medical students, was topographic versus organ-specific, organ-wise, systemic. It was from formalin-preserved, embalmed bodies to formalin-sterilized in the operation rooms. It was this simple when we were students. It doesn't remain this simple anymore. There were only plain skygrams and radiograms. So now radiology has improved so much that you need to understand radiological anatomy. while you prepare to become a surgeon or operate on a patient. And then progress in biomedical technology has brought in minimal access surgery, which has actually forced us to understand tangential anatomy. While you do open surgery, it's perpendicular anatomy. You move your head and your eyes do not move like in other animals. So you can only see perpendicularly. Whereas the scope and the camera sees tangentially, and if it is a 30 degree or a 45 degree, with a small flip, you can actually see the depths from various angles. And this is something that needs to be understood. And it can be positional. Esophageal surgery initially was in lateral position, and then it shifted to prone position, and then semi-prone position. Anatomy had to be unlearned. I actually did esophageal surgery for about 6 years in lateral position. It was so difficult to actually orient myself to prone position. It's much easier for the younger ones now because sequential training happens. They keep seeing lateral position for lung and prone and semi-prone for esophagus, so they understand anatomy much more easily. And then it becomes magnificational also. You see a little too much, and then you get worried that you will hit something. It has become 10x in the robotics. It ranges from 2x, and then the closer you go, it can look much bigger and much more scary. And from open to endoscopic, it's not just 2D. You need to wear glasses and goggles, and it is 3D anatomy. Once again, initial part of your learning. It can hurt your eyes. It can hurt your head also. So it does all this. Surgical anatomy does not stay as simple as it was before. So it doesn't stop with your cadaver dissection. It's not an extension of your anatomy in the first and second years. It's much more that you need to learn as a surgeon. Technology has challenged us significantly. You can see that a 3D reconstruction, you can see a mole exactly reconstructed. You can see a bindi reconstructed. You can see hair being reconstructed. So the challenge is you know where to cut. It's important to cut correctly and not remove what needs to be retained. All this is a challenge that the expanding technology has extended to us. Anatomical issues. It's important to learn deft handling of instruments, usage of your fingers very nimbly, so that you won't end up with a specimen with a parathyroid there. And if it happens bilaterally, you are creating a parathyroid triple, because it's not easy to replace parathormone, and calcium is something that may be necessary in grams and not milligrams. Important to retain the vascularity. It's not the structural integrity alone, because thyroid and parathyroid share vascularity. They are in different capsules, all right. But if you are not the best of surgeons, you will end up with significant number of patients who have tetany. You can see multiple vessels running across the parathyroid, and when you actually get the thyroid out, the parathyroid should look like this. It should not look red. It should not look black either. Preservation of anatomy, and this is something that we have seen 4 times. It should be much more common in the general population. Non-recurrent laryngeal nerve, embryological aspect. One of those days when I was impressed by a radiologist's report that a patient with thyroid swelling here, a big large thyroid swelling here, the radiologist had reported that the patient has a retroesophageal subclavian. So kindly look for, the report says, kindly look for a non-recurrent laryngeal nerve on the right side. This is serious contribution from the radiologist. So they need to be anatomical. They need to understand what can be associated with what they have already seen. Nerve is not something that the radiologist can see, but they can warn the surgeon that this can happen. So we were much more careful than on any other day. and that's what it was. You can actually see that the rectal nerve is coming off from the cervical part of the vagus. The vagus that is dipping down gives off the nerve and then goes down into the thorax. Much lesser attention to the superior laryngeal nerve because it escapes injury more often, or the injuries are not always do not always become too symptomatic that the patient complains of hoarseness or things like that, but it's an important nerve because it can produce laryngeal anesthesia and cause significant morbidity in terms of voice fatigue that these patients can have. It's also important to understand that if you have to do a total thyroidectomy, thyroid does not confine itself to the lobes and the isthmus. It's much more than that, and whenever you do that pyramidal lobe and then the isthmus, the pyramidal lobe and thyroglossal tract is something that needs to be excised in every patient if you are thinking that this can be cancerous. If you have already proven it or you understand that it is cancerous, because of the simple reason that these patients, once you have done such a good job, although it is said that true total thyroidectomy is rare, you can achieve that if you stick to certain principles and resect everything that you can actually see. And you will always also prevent when the nuclear medicine physician tells whole body scan reveals no evidence of residual thyroid tissue in the neck and no evidence of functioning tissue, indicating good ablation. Ablation can be done by the surgeon who is better trained than others. Situations like this lady's complaint was that she's not able to feel her ear ring. Ladies would be very interested in showing off their rings, and they would always want to feel it because once there is anesthesia here, what can happen here? That's what she was complaining. What can happen is they can actually lose the earring, which could contain diamonds. Can be a serious loss. Apart from the sensation loss, it can be financial loss also. We need to understand that the auricular nerve has 3 branches, and it's important not to cut here. Important to actually uncover all the branches, and the one branch that goes to the nerve, or sometimes 2 branches that go to the nerve, should be preserved. There's no compromise as far as the peritoneectomy is concerned, but the nerve stays there, and these patients have no anesthesia. So some of my childhood heartthrobs could have such huge earrings, and if they don't have anesthesia here, these are some things that they cannot wear. The other important aspect is, as I learned, we would always do a total conservative peritoneectomy for deep lobe tumors. The superficial lobe was sacrificed because we thought it was coming in the way. But later on, we understood that for pleomorphic adenomas, at least, what can be done is to preserve the superficial lobe and then remove the deep lobe and put the superficial lobe back and suture, so that the deformity and the phrase syndrome both are avoided in these patients. So it's all preservation of anatomy with in a relentless pursuit to give the best result, both cosmetic and functional, for the patient. If you are a minimal access surgeon or an open surgeon, the anatomy can be really different. It can be as good as this, wherein you can see through all the structures. Good for a young surgeon who is starting to do these procedures. But it's not always your choice. The next patient could have fat all over, difficult to go in, difficult to come out, difficult to perform. and then bowel can keep disturbing you continuously. So this is some anatomy that you cannot choose, because patient's lifestyle is not something that is in your hands. You are only qualified to treat them with the disease that they have. Tangential dissection that I was talking about, you are standing on the right side now. You didn't start anterior to the inframesenteric artery in a abdominoperineal resection. You have started dorsal to the inframesenteric artery, and then you have identified the ureter. You're preserving the facial plane so that the entire autonomics drop down. So this is something that needs to be learned, and if it is learned sequentially for the teachers here, it's not open surgery that's learned first and then minimal access surgery learned later. It's always good to train students simultaneously. They should learn both the techniques simultaneously, and the best training happens when you actually learn all types of procedures simultaneously. Splenic artery is something that can be a real spiral. Until you hit one, you never think that it can be such a big spiral. You can actually see that it's climbing up into the hiatus of the esophageal hiatus, and then it is reaching the fundus here. So if you are not really careful here, you can hit the one of the loops here, and it can produce significant hemorrhage. So it's important to identify anatomy. One of those days, the left gastric artery has been isolated. We were doing a D2 lymphadenectomy, and then there was something here. We thought it's a node, and it's always important to chip slowly, because the splenic artery has not been identified. The vein has been clipped. Splenic artery has not been identified. Till you do that, it's important to be careful. And with all this tissue lying in your field, important not to push up any instrument that and then shear it. What was injured was the splenic artery itself, something that was like a spiral, like the previous patient. We clipped the left gastric, and then we found that it was a real spiral. It's indeed important to keep on chipping slowly so that the artery comes out. It's a big, large vessel, and it's not easy to injure it if you have seen it. If you have not seen it, then anything can be injured. The challenge in rectal surgery is also, again, anatomy. Localization is a major challenge, unlike the open surgery, because you don't have haptic feedback there. So there are various methods of doing it. You can do a pre-op colonoscopy and inject Indian ink, or an intra-op colonoscopy. That's what we have done, and we mark from the laparoscopy. So we call it the laparoscopy colonoscopy. We do that, switch off the laparoscopy light, and then localize that, put a clip or burn it there, so that while the laparoscopy light comes in, it becomes easy for us to identify where the lesion is. The other method is to inject the Indian ink. I don't know what is the Indianness in Indian ink. It is something that is not available in India more often than not. And whenever that happens, and it is indeed important. It's an inert dye, but it's important to inject very little into the mucosa. Our gastroenterologist could not get hold of Indian ink, so injected methylene blue. Methylene blue is a vital dye, and it can completely destroy the anatomy. So it's all about anatomy. He wanted to help us, but he made it much more difficult. There are clinical signs of the lesion, like the puckering of the epiploicae, the whiteness of the otherwise pink colon. These things are lost because of this injection. Everything is blue. It's important to apply anatomy. One of those days, one of our trainees then, went in, started too high, he was doing a AP resection, started too high, he did not start at the sacral promontory. It's important to follow steps very carefully. Went in, not the best of visuals also, high definition systems then, that is the ureter. Went in with a harmonic, did not identify the infamous centric artery. This was a review of the video. And then went to the right side of the aorta, searching for the infamous centric artery. And what he could see, he should have seen is one branch that is going down, the lumbar. It did not click in his mind. And when I came back, I saw only a vein there, and I was shocked to see that the infamous centric artery was chopped at its root. Because we actually looked for it, this patient was saved. Otherwise, if there was a bleed post-op, they can just exsanguinate. So it's important to understand that the infamous centric artery never gives a branch on the right side. Leave alone the caliber of the vessel. The caliber itself was much larger than one would have expected, but there is never a branch on the right side. All its branches, starting from the left colic, are on the left side. So these are things that should play on your mind while you are doing these procedures. Not an easy procedure, the D3 lymphadenectomy. One of those days when we actually started in the middle, such formation of the superior mesenteric vein is something that you rarely see. It's generally one big vessel that goes up. You can see a double superior mesenteric vein joining together to become one. Once again, we need to be very, very careful. Augmented images make things much better. 4K videos now, they were all high definition before, some of them are analog, makes things much easier. What it actually does is it shows you anatomy better. You're straight on the vessel, and then you can keep seeing in various modes for a good lymphadenectomy. So the lymphadenectomy is being guided by augmented reality. You could have something like this, good for a junior to do a liver resection, completely lobed liver like this. It's a delight for a young surgeon. And you can also have liver lobes on the gallbladder. You can do a lap chole and claim that you have done a liver resection. So these are things that are not really uncommon. If you start seeing them, you will actually see them and record them. One of those days when we actually saw the images but did not pick this up. When we went in, we saw that the left lobe of once again, a lobed liver, and the left lobe was far away with a good vein and an artery supplying it. An accessory lobe. You can see a big, large vein and an artery running to it. So we went back to see the CT scan. Neither did the radiologist report it, nor did we see this before we actually saw the video. So you are learning it backwards. I'm happy we are learning at least. Axillary hepatic artery is something that can be challenging for learners. It's important to understand that it's not uncommon. It's reported that it is seen in a significant vessel is seen in about 16%, but we find that it is seen in about 30-35% of patients. So it's important to preserve it because it can supply a significant part of the left lobe, and it's not difficult if you have actually seen it. One clinical indicator is whenever you have this vessel, generally the lesser momentum from the span of lesser momentum from the liver to the stomach is much longer. So if you have a J-shaped stomach or a lesser momentum that is much longer, always suspect that you will have a accessory hepatic artery or a replaced hepatic artery. Started doing ICG for everything. We injected ICG into the vein to only see that the liver takes it up immediately, one of those gallbladder resections. So serendipitously, our boys started doing it. Sarjan Shukla, Nusrat, Ajesh, and Naren started injecting it into the inguinal nodes for the sake of identifying thoracic duct. And when we did the laparoscopy, we saw that the liver was not taking it up. Now it's getting into the lymphatics, and then showing excellent anatomy of the CBD. One procedure for the young surgeons that's always worrisome, especially in chronic cholecystitis, multiple attacks, is to identify the CBD, and this seems to be the best technique. You can actually see the gallbladder, the CBD, the right hepatic duct, the left hepatic duct so clearly. In subsequent cases, we started doing this regularly, and liver doesn't take up, so the contrast can be very, very clearly seen. So real-time dissection of the colloids can be done like this. So it's a flip of the camera, one button you press long, and then suddenly you see such immaculate anatomy. You can see the cystic duct there, and even in the worst of the situations, in even a post-operative situation, you just see this. You can see the angulation between the cystic duct and the CBD. So if you can see like this, even the least trained surgeon would not hit the CBD. You keep climbing up like that. You can see the right duct and the left duct. Keep dissecting, and it makes life so much easier. And it would cost only a few rupees, because when the vial costs 1,800 rupees, and we use it for 6 to 7 patients in a day in a high volume center, it costs you 200 to 300 rupees extra. And CBD injuries are not simple injuries. They make some patients biliary cripples. The right duct and the left duct, you see everything so well. You can actually see the whole length of it, and the biliary system retains it because ICG is practically excreted by the liver. It's not excreted by the kidney. Close to 100% of it is excreted by the liver. So you see it for 3 hours, 4 hours. You don't have to be a very rapid surgeon to make use of this. So excellent technology that is augmenting the anatomy. You can actually see there. This anatomy, the biliary anatomy, is generally something that can get the best into trouble because of anomalies. So it's important to be much more slower, much more steadier while you do this, till you really confirm that the cystic artery is truly getting into the gallbladder. It's important. One of those days when a caterpillar hump, I myself thought this is a cystic artery, only to understand that it was the right hepatic artery, giving away the cystic artery a little lower. You can actually see it here. So these dissections for a cancer of the gallbladder, the better visuals with the 4K and the 3D systems have made these procedures much more easy. The left gastric vein, the gastroduodenal, the hepatic, the CBD, the right hepatic that is running like a caterpillar hump. So anatomy is something that needs to be seen, and the best way is to see it preoperatively if possible. Read your scans well, reconstruct your scans well, and read them well. And if you don't have that chance, it's important to be very, very slow. We were surprised. Suddenly, we were dissecting for the hepatic artery. We found a vein here, and that was the portal vein. So a retroportal hepatic artery we didn't have a clue because we didn't do a vascular reconstruction for this patient because it was a gastrectomy, and for gastrectomy, very rarely anybody does a vascular reconstruction. So it's important, irrespective of what you are doing, it's important to bite little and then coagulate and cut. One of those anomalies here, the middle colic arising from the hepatic artery. Not easy while you are doing the Whipples because it is running across the pancreas. So what we had done was we delivered the jejunum out and then achieved a clearance here. That is a pancreatic cut margin. So we preserved this. We actually clamped it and saw the colon was maintaining vascularity, but because it was not a part of the margin, so we retained it and then did a good anastomosis of the pancreas. Multiple vessels are something that can happen, and it's very common in the genitourinary system, especially the renals and the gonadals. So whenever you have two veins, it's not uncommon to have two veins. If you already have a vascular reconstruction, if it's a protocol, then it makes things easy. Otherwise, you always expect these problems because they are not uncommon. And whenever you have two veins, always look for the artery in between. Never dig from one side or the other, because you will have a chance to injure one of these veins without actually getting a handle on the artery. And if that happens, the bleeding will be significant because the artery is still perfusing, pumping into the kidney, and it can back bleed. So each time, every time, when you have two veins, the artery is always in the center. And you can have many more, 2 gonadals and 3 arteries in this patient. None of these patients pay you a pie extra. The stress and strain that you go through, the number of clips that you use increases significantly. All this is decided by the patient's anatomy and not patient's attitude or patient's financial comfort or discomfort. So we need to be ready to see all this, and to see this, you must uncover anatomy slowly, steadily, irrespective of what procedure you're doing. 3 arteries and 2 gonadals, all of them clipped patiently while we did this nephrectomy. Ureter is also extremely important, much more for the gynecologists than the surgeons. Surgeons are much more confident about them. Ectopic kidneys are not uncommon again. With the imaging systems, they always detect this, and it's important to understand that ectopic kidney always has ureter in an ectopic site, and it's not easy to dissect it out. We were doing a anterior dissection, and it took us 1 hour to actually identify the ureter. So going on pushing and pulling, ultimately we saw it peristalls across the transperitoneally. And it's also important to allow nothing to bleed here, because any bleed can actually spoil the anatomy, and once it bleeds, it becomes much more difficult for you to identify the ureter, and especially if you are dissecting against a tumor like this. It doesn't give you too much of space, so it's indeed important to see that there is perfect hemostasis while you actually reach the ureter. And see through the peritoneum, so it becomes much more difficult. And duplication is, as I said, in urinary system is very, very common. It's important to preserve both the ureters, and never do they move together. Like 2 wives, if one of you has, they never think together, they never move together. So you can mistake one of them to be less important. And it's also important while you're doing pelvic surgery to preserve the mesoureter. It's much more challenging while you're doing this for a double ureter. One of them necrosis, it becomes a serious problem that can the other one also can get significantly infected if one of them leaks. So it's important to preserve the vascularity. It's much more challenging when you have a double ureter. You could have much worse. We were doing a nephrectomy in a young child. You were going on searching for the ureter, and And while we were searching, it was actually behind the cava. It was between the cava and the aorta. The retrocaval ureter is not something that is unknown. And there are situations when children have hydronephrosis, and it may need to be cut here to be transposed in front of the cava. Here, because it was nephrectomy, we had to go between the aorta and the cava and cut it, flip it out, and then complete the nephrectomy. So it's important to understand that all this can happen to patients. In the pelvis, it's all dorsal vasculature. It's important to preserve that. Ventrally, you can be dissecting close to the ureter, but dorsally, it's important. Lateral vascularity and dorsal vascularity needs to be preserved if you don't want fistulae or if you don't want strictures in pelvic surgery. You can actually see that the internal iliac artery is giving off a vessel here. If you can preserve this, the function of the ureter gets preserved. Otherwise, a small number of these patients can become cripples. The urologist keeps doing stenting, and then it gets infected. They remove the stents, and then they keep visiting the urologist. If you're careful on the table, you would make them much more comfortable for a lifetime. Very important to preserve. Keep on stressing this fact that you need to preserve everything. It's close to the ureter. The mesoureter is something that needs to be preserved. It's important to play very close to the peritoneum here. Don't lay it bare. The ureter should not look white in color. It should have some yellowness while you dissect it in the pararectal fossa and the paravesical fossae. This is something that I would never want anybody to do. Stenting a ureter for the sake of identifying it is something that is very harsh, because stenting itself can produce problems. Ureteric serious injuries are reported in 1% of patients. If you cannot identify ureter, I think you don't deserve to do pelvic surgery. Stenting is something that I would always tell you, it does add to your intelligence, but it makes the patient miserable. And if you have cut the ureter, how do we identify if you have already clipped it? The ureter, actually, the cut section, unlike a vessel, looks like a flower. You can actually see here, this was an exentration that we were doing. It was not an accidental cut. So it actually looks like this. The cross section looks like a flower. If you have cut it accidentally, then it's not a floral tribute to your surgical brilliance, but it does look like a flower. I would always say that it's easier to handle women's ureters than women themselves if you are gentle. Retroperitoneum is a minefield for arterial anomalies, and these dissections are difficult, especially in minimal access. They need a big incision if it is an open surgery. Those are the gonadals, that is the IMA, that is the renal vein. So all this, when you are doing, these are procedures that are not simple. Really appreciate the team that I have, especially a boy called Srajan Shukla. He's an expert in these vascular reconstructions. Each time he's in the radiology department. In fact, he has taught our radiologists how to do this vascular reconstruction. So we image everything very carefully before we go in. This was a double cava. And then you have a lower polar vessel, which we actually noticed it up front. We preempted it. And that is the IMA, a lower polar renal vessel from which the gonadal was taking off. So if you have identified it, there's a very little chance of injury. Otherwise, when you're doing this procedure, you might go across and chop this off. So it's important to do a vascular reconstruction. Radiological anatomy is important. There can be double gonadals here. There are double gonadal arteries, double gonadal veins. Everything is possible. And all these can be seen very well if you have done a good reconstruction. And to make things much more difficult for you, there can be a horseshoe kidney in a patient who is high-risk endometrial cancer. And to work around the isthmus of the horseshoe and complete this procedure is not a simple challenge. The IMA is like a hook over the isthmus there. That is the left renal, that is the kidney, and that is the isthmus. You can actually see that the IMA forms a hook there on the isthmus. So you dissect deep into it and then clear all the tissue. This is something that was seen here very, very clearly before we actually prepared. So it's important. So whenever we see this, we sleep early, wake up a little late, and then do these procedures. What can be much worse is ascites inverses, wherein you have to do the same procedure, the spleen on the right side, liver on the left side, the gallbladder on the left side, stomach on the left side, the cava on the left side. Can be very, very difficult because the IMV on the right side, the gonadal here, can make it very, very difficult. The right renal vein crossing the aorta and traveling towards the right side to join the kidneys. Not easy at all. So difficult anatomy, but it's very ecstatic when you uncover it and do not produce any problems for the patient. Anatomy in prone and semi-prone positions. Suddenly you realize that is the spine, and then this is the bronchus, that is the azygos. Something that you need to learn systematically. One of those days, it's important to have the best visuals. HD visuals not at their best. You need to clean, you need to heat up the tip. You have not done that. Something that was looking blue, and a shear like this can be dangerous on something that was blue. There was something blue here, this was a node, and something that was blue here also, something that comes up blue, that is a lymph node, but this actually is not a lymph node. When you don't have the best of visuals, that was the inferior pulmonary vein, and that's what can happen. Chandramohan was in the operation room on that day when this happened. We could clamp it and suture it bronchoscopically. What is much more important, Chandramohan wanted me to show a few videos on thoracic duct. I never thought thoracic duct can look like a saccule. I always thought it is a tube. I thought this is a lymph node and went across it with a ligature, only to see that it was leaking in liters on the table. I don't know, a patient who is fasting should not be having so much lymph, but it was continuously leaking. And those were the days when we were doing these procedures in prone position. Patient had a spine that was projecting into the thoracic cavity, so the instruments were not getting in easily. Not easy at all. We went in, I took 10 minutes to do this procedure. The left hand was not going in, so we just held the pleura, went in, and could pass a clip across. It's much more easier in semi-prone or lateral position. One of the head and neck team had this problem of lymph leak after a thyroidectomy. It was done in a medical college hospital. Our head and neck surgeons explored it, only to find that it started leaking again. The only option was to go lower than where they have explored. So we went into the thorax. The key here is to identify the azygous vein, which is very, very simple, and then stay ventral to it. Hug on to it, stay ventral to it, and dissect dorsally to reach the aorta. The whiteness of the aorta, the blueness of the azygous vein are something that is important. And whatever tissue that drops down would always have the thoracic duct in it. 100 out of 100 times, you don't need to do a biopsy. And once you clip, if you wait for 5 minutes, what happens is this will dilate to become a saccule again. And we remove the chest tube, in about 2 days. Bronchial arteries are something that need to be preserved. Otherwise, the chances that the patient will have bronchoria and need for ventilation postoperatively would increase. That is the right bronchial artery arising from the aorta. If you can uncover it like this, coming down like that into the bronchus. Left one can be inconsistent. You think it is inconsistent, but as we progress in esophageal surgery these days, we look for it in this triangle. The right one generally takes off here, the left one takes off here. And left one, the major part of the left one generally is something that comes down the bronchus and then turns upwards and supplies the inferior aspect of the bronchus, unlike the right bronchial artery, which actually is on the membranous part of the bronchus. You can actually see the bronchial artery there. Deliberately, you dissect. And when we started doing this, each time we are finding a significant vessel that is coming down. We have been sacrificing these vessels. There is a lymphatic that is coming down from the thoracic duct there. So we have clipped that. There can be a lymph node close to the artery, and there is one there which is being teased out. The artery comes from there, and it can be a small spiral. That is the bronchus there. And once you need to really spend lots of time here so that the patient spends much lesser time in the intensive care. You spend a few minutes, patient spends less time by number of days actually, and then the amount of antibiotics, the hospital stay, everything comes down significantly. You can actually see the vessel there now, completely uncovered and pulsating there and entering into the bronchus on the inferior aspect. Veil of the thoracic duct. For the younger ones, it's important to identify the vein, which is not difficult, even in the burst anatomy, and then cut the pleura there. What is important is good counter traction by the surgeon's left hand preferably. And then when you do that, automatically the fatty portion between the aorta and the azygous vein is something that needs to be left behind if you want to do a good dissection and save the thoracic duct from any injury. So that is the plane. These are the vessels that are running down the vagus. So as long as you preserve this fat pad, the thoracic duct stays safe. Thoracic duct all along in the upper chest, it's much more difficult. You can actually see the thoracic duct rotate right side and go there. The chance of injury here are much more. You have to see all this with naked eyes or with the scope. It's a little more difficult than when you use technology that is much more recent. You can actually see here that we have injected it into the inguinal nodes, into the node, and everything becomes so simple. This was in real time. The video is faster, but it was done in real time, and that's how much time it takes, because you know where you are dissecting. You don't have to be unduly careful because you are actually seeing, and when you see well, you do well. So all the dissection is centered around the thoracic duct. You are actually staying next to it and dissecting it free. So technology is something that you need to accept, need to absorb, need to buy and use it so that your patients remain safer than they were a few years back. Keep dissecting into it. The duct is seen. This confidence was something that was missing while we were doing. So you don't shift to the other side at all. Once you start on the left side of the esophagus, you complete it because of this technology. Thoracic duct branches are something that we are seeing now, something like a teardrop that you can see. Watch carefully here. You can see some greenness here. We became a little alert because you can actually see that the lymph is flowing down into it. With the heartbeat, you can see that there is a duct here. So we have seen it before we cut the pleura. So we know where to pass a clip so that there will be no leak later on. One of those days when there was a much more difficult duct, a subcarinal lymphatic, which was long and large, which was draining into the thoracic duct, coming down into the subcarinal area, passing across the bronchus and getting into the thoracic duct. These ducts, if you injure, there can be a leak. Even if you have actually saved the main thoracic duct, it's like something like a hole in the side of the duct, so which would be as bad as injury of the duct itself. So augmented reality is something that can help you avoid these uncomfortable problems and avoid a next second surgery. Salvage esophagectomies are something that we are known for. We have done close to 20 of them after radical dose of radiation therapy, sometimes after 5 years, 6 years, one of those patients after 10 years. Not easy at all. So with the best of visuals, the 4K 3D visuals, slow cuts, and the augmented thoracic duct anatomy. As you come down, separate the thoracic duct, and then go in. Can be this difficult. That is the aorta. This is the esophagus. It's much more radiation fibrosis than disease itself. So you keep chipping, and there is one small duct that is going downwards here. All this was not something that was not seen when we did not have the technology at our disposal. So that is the aorta. Keep climbing up and getting close to the adventitia of the aorta. And once you do that, everything falls in place, and nothing that is operable on CT scan becomes ever inoperable, even if it is in a salvage setting. Not simple these procedures are, but it's all achievable if you have a good team that you develop over time. Nerves are also important. The suprazygus portion is much more crucial and critical. You want me to stop, Chandramohan and Abhilash? I'll stop. I'll take 5 more minutes, maybe. The referential nerve, the phrenic nerve that you have already seen. Perfusion is also something that can be augmented. If you are young and you don't know what is happening, you can use the technology to understand anatomy, the morbid anatomy, so that your anastomosis becomes much more safer. And what has been added and is being tested in the institute is what is called the QP, wherein you measure how much vascularity is there. As you come onto the surgeon's hands, it becomes 0. The glove is 0 in vascularity, and then the green is highest, and then color segmented. The blue is the lowest, the fat is the lowest. So everything is measured, quantified objectively, so that you don't commit mistakes in anastomosing in an area which is less vascular. Simple tools, 1 ml of the dye that is injected, and then you just open this camera and understand where you should anastomose. One of those patients on the post-operative day 5, pre-op, patient was becoming breathless. So we did a CT scan and understood that there was something seriously wrong with this patient. We went in laparoscopically, and realized that there was a diaphragmatic herniation. Went back with the same ports after a esophageectomy. And we brought back the transverse colon. We could actually see that the entire diaphragmatic hiatus was torn, and that was the reason why the diaphragmatic hernia happened on the 5th postoperative day. So we brought it back and sutured the diaphragm. What had happened here was there was a bleed. We were doing transarterial esophageectomies. Then what had actually happened was there was a bleed in the mediastinum, and to secure the hemostasis there, en route there was a lot of shear on the hiatus, and hiatus widened significantly, which we actually never noticed. So this is what happens when all your mind is at the tip of the instruments. What happens is everything gets torn. So it's important the camera picked it up, but our eyes did not pick it up. You have a robo, these things can be a little more simpler. You can see these nerves much better. So to sum up, anatomy plus common sense is surgery. And when you talk about surgeon's common sense, it is also called surgical sense. We keep telling he has great surgical sense. And whenever you're talking about common sense, never criticize or comment on the common sense of or choices of your wife, because you are one important choice of her. The role of anatomists and surgeons in clinical anatomy instruction is something that needs to be stressed. In the olden days and in the West, anatomy and the surgery professors were the same. And that is probably the best situation. The surgeon, when he teaches anatomy, then the best teaching happens. No matter how much higher the position we go in life, each one of us, our anatomy dissection hall memories always remain very nostalgic. The University of South Florida developed a system of instruction wherein, as a patient to be operated is prepared for surgery, medical students on duty should review the anatomy with the help of a surgeon and an anatomist using anatomical illustrations, radiographs, MRIs, computer tomographies. This is made as a protocol. If you can do that, it's the best. And if you don't have cadavers, you have augmented reality these days, virtual reality and augmented reality that's coming up. So anatomy is something that separates the best surgeons from the rest. Become comfortable with anatomy, both normal and morbid. Identify everything, decrease complications, decrease need for blood transfusions. And it's important to open a book page by page. Don't tear pages. As said by one of those great esophageal surgeons, what forces you actually teaches you. Fear of leaving behind disease in oncology is something that taught me anatomy. I went on dissecting for fear of leaving behind disease and thus explored anatomy. The best anatomist makes the best surgeon. Anatomy and its anomalies actually keeps me engaged, entertained, and excited at this age. Dear young ones, it's important to have plain discipline in surgery, just the same way as you have lane discipline in traffic. Never clamp and cut, whether it's minimal access surgery or otherwise. Keep on chipping and chiseling to uncover anatomy. Preempt anomalies, prevent problems, and produce solutions for your patients on the table itself. And it's important to preserve nature. Each small part of the patient is important. Preservation of anatomy, preserve anatomy, which is the richest attribute of nature. Everything is so carefully done by Lord Almighty, and that indeed is the greatest tribute to the Creator for his deft creation. Thank you very much for your patient hearing.
Thank you, sir, for the wonderful presentation today. All the residents and all the surgeons of ASI Trivandrum has been immensely benefited from your talk. Any questions from the panelists? Let me go to the my let me go to the vote of thanks. Before that, I have an announcement to make on behalf of the ASI Kerala chapter. The ASI Kerala chapter Kasicon 2021 is going to be held, is to be done by ASI Calicut chapter, and it is to be on the days of July 10th and 11th. So everybody is asked to join the Kasicon also. Thank you all, all dear faculty members, dear surgeons and residents, and very thank you to T.S. Rao sir for joining us for this meeting. Thank you all. Thank you.
Very much. Thank you, Chandramohan, Abhilash, and all of you. Thank you.
Thank you, sir.
The meeting is coming to an end.